Hi everyone, good evening and a warm welcome from Monash University. My name is Liz Lopez and I'm the Communications Manager at the School of Translational Medicine, which is co-located with Alfred Health in Naarm or Melbourne. Thanks everyone for joining us tonight from around Australia for this webinar on autoimmune encephalitis or AE. We'll have links in the chat and also following this event by email to anyone who's registered and can't make it tonight. A reminder that this event is being recorded and some excerpts may be used in our communications. So please turn your camera off during the Q&A if this isn't for you. Autoimmune encephalitis, as some of you already know very well, is a trickster. But before we kick things off, I'd like to acknowledge the traditional owners of the land we're coming to you from in Melbourne's southeast, the Bunurong people of the Kulin Nations and their elders past, present and emerging. And of course, any First Nations people tuning in online or among the clinicians in the audience. Our first speaker is Professor Mastura Monif. She's a neuroimmunologist seeing patients at Alfred Health, and she's a senior researcher in our Department of Neuroscience. Mastura is going to give us a rundown of what AE is, who it affects, what we know and what we don't know, and later where the research is leading us. And then we have three community members. Each of our invited speakers has, without exception, said that they're here tonight because if they can help even one person through the maze of diagnosis and treatment, it'll be worth it. Amber Cason lives in Perth and works as a karate instructor and a music teacher, and she's been living with AE since 2013. Then we have two speakers, both parents of an adult child with AE, with somewhat different experiences of navigating the health system. What all three have in common is that they are very effective, persistent advocates. Michelle M lives in Melbourne and her son was diagnosed at age 21 and he's now 28 and appears to be doing really well. And Amanda Wells will be known to many of you from her dedicated involvement in the International Autoimmune Encephalitis Society. Amanda lives in Brisbane, right in the path of this week's as well, Cyclone Alfred, no relation to the health service. We're lucky she's not too badly affected by the mop-up and can join us tonight. Amanda is one of the admins for the IAES Facebook group, which you can join if you have an AE diagnosis. Community members who volunteer for clinical trials as carers or as people with lived experience are really important for raising awareness of a rare or newly identified disease. And this has really important implications for research funding, for clinical practice, and to make a case for targeted support. And right now, this condition is very difficult to get NDIS support for. Every experience of AE is different. We have, as you'll hear from our speakers, we have just 1 hour, so we're packing a lot in. So, Professor Mastura Monif, you research all sorts of conditions such as multiple sclerosis and brain cancer. What led you to autoimmune encephalitis, and did you know what it was when you first came across it?
Thank you, Liz, for that very important question, and thank you to our panel members and all the community members for attending tonight's event. So autoimmune encephalitis, when I first, what led me to it was basically one individual patient story. At the time, I had heard about autoimmune encephalitis, but never seen it. And at that stage, I was a registrar at the Royal Melbourne Hospital, and I was on call. And at the time of being on call, there were multiple emergencies, and this patient was already in the ward. And so when I saw them, it was approximately 8 p.m. At the time, they were having recurrent seizures. I started an anti-seizure medication, went downstairs to see another emergency patient, came back up, and this patient continued to have seizures. And then I started another anti-seizure medication and then subsequently gave them another medication. And in that time, this individual continued to have seizures to the point that it was becoming almost one seizure a minute. And I could actually see it on his face that he was becoming more and more distressed, but he was also at loss as to what's going on. And myself, as a registrar, was also thinking this is not the usual type of seizures that we see commonly. This is not the type of epilepsy that we would see normally. So what is going on? And even at that moment, something triggered to think, okay, this is not the usual of what we see, so something else might be happening. So that individual ended up having anti-LGI1 autoimmune encephalitis later on. But even from the very outset, it was clear that this was a different scenario, a different condition. But it was essentially just seeing the distress in this individual's face that led me down the path of trying to understand this condition, if we can in a better manner, so we could hopefully improve patient outcomes.
sort of possibilities crossed your mind? Because we know that AE, the symptoms often overlap with other conditions, and people can run the gamut of different specialists and types of doctors.
At the time, of course, when you see someone with a seizure, you think, okay, is it epilepsy? But this individual didn't have epilepsy to begin with. And an older individual who doesn't have risk factors for seizures, it's a bit unusual to have seizures all of a sudden. And so I think at that time, there were some red flags already, but it also came down to trying to understand what was happening in the lead up to this presentation. And this person had cognitive issues in the 2 months prior. So I think trying to, because autoimmune encephalitis can mimic many other common conditions like dementia, like delirium, like, other neurological disorders or primary psychiatric diagnoses. So I think trying to get a history from the individual, and of course in this scenario the individual was unable to provide a history, but getting collateral from their family members to understand what other red flags or what other what else is there that fits or does not fit the common presentations, or what could it be that would tell us that potentially we should actually look for autoimmune encephalitis, or at least something that tells us, hey, this is not what you were thinking. Try and understand it better and do the investigations and appropriate plan. So I think, yeah, just being mindful of the subtleties is important.
Is it just a case of realizing that you need to put AE on your radar, or are there specific symptoms that distinguish AE from all the other things that people try to investigate? Like, is it cancer? Is it an infectious disease?
I think number one is having AE in our radar, and given that it's a rare disease, so it can affect up to 15 per 100,000, and that varies from region to region. So it's a rare disease. So I think whether we are in emergency department or in a neurology department of a tertiary hospital, or in a primary center or like a rural hospital, I think if we know about the condition, that's quite important, because it's at least at the forefront of our mind, and then so then we can actually look for it. So I think that's important. But whether and at times majority of cases the individual will not have AE, and that's a good thing, but I think it's important to think about it.
Thanks, Mastura. And you raise a really interesting point about there often being no history, because this can come out of the blue and strike apparently from nowhere, and it's only in hindsight that people realise, oh yeah, there was something going on in the lead up. Our next speaker is Amber Cason. Amber lives in Perth and was studying music at university, looking forward to an honours year, when she came down with some alarming symptoms. We had an unusual phone call last week in that Amber was accompanied by her mum, Martine, not because she isn't more than capable of speaking for herself, but because there's a whole year she can't remember from the time she was diagnosed. Amber, what does it do to your sense of who you are when there's an entire year missing from your memory? Oh, Amber, you're on mute.
There we go. It makes you question who you are, because who are you if you can't remember the things that you've done? Who are you if you can't remember where you've been, the things that you've achieved, going on holiday, taking pictures? You begin to lose a sense of, was I there? Was that me? Didn't feel like me. I don't recall it. Is it sort of a case of feeling as though it's a story that you're reading back on and not actually remembering your own life?
Martine, you are effectively Amber's memory for this period. What happened?
Sorry, I always get so emotional when it happens, because it was so hard. I noticed something was wrong when nothing made sense. She'd put her bags in the back of the car, and she'd get into the car and she'd say, "Where are my bags?" And then I knew something was wrong. So we took her to the hospital, and she was there for 2 weeks. They said it was viral encephalitis, but she was discharged after 2 weeks with no direction, except you've got a OT for once a week for the next year. And if it wasn't for the OT, I don't know where we would be today, because she brought Amber out of the woods eventually. It was so hard for Amber and myself, because Amber would break down and I couldn't help her. And we moved forward with the OT, and she still has the same OT today. And I think she's just helped Amber along. And we then found Dr. Mastura, and I think things moved forward faster with Dr. Mastura. And I think we at a great place now.
How long did it take to get the diagnosis of autoimmune encephalitis?
Well, still today, I don't think they're 100% sure, Dr. Mastura. I think I'm right in saying that.
Martine, there were times when Amber seemed to zone out a bit, but it wasn't that she was just distracted. What was actually going on?
Correct. So I used to think she was tired because she lived a very active life, studying and doing things. And I used to say, don't worry about it, she's just tired. And then one day at university, her lecturers came to her and said, Amber, do you remember doing these things? And they were normally for about 40 seconds, not more than that, where she'd actually zone out. And he said he's got 3 kids who have focal seizures. Please go and have yourself checked. And I think I have missed that for quite a few years. I didn't even know she was having those because you can't see it. And then that was the focal seizures. And then Amber can tell her about the incontinence that happened after that.
Amber, what's been the most challenging aspect of living with AE for you?
The most challenging thing is that it's invisible. I look perfectly normal. I had come from studying at university, doing lots of activities, karate, music, to being in hospital for 2 weeks, at home recovering, and even now fatigue plays a huge big role in what I'm able to do and what I'm not able to do. And it's very frustrating to when I'm involved with people and I have to engage with people, to express the need to, okay, look, I need to take a break now, and not appear lazy and not appear like I can't be bothered doing the things. I lost friends over people who thought I was making it up, couldn't be bothered, too lazy, etc. And so it's been really hard to find that sense of self-acceptance. We're going, okay, well, it actually doesn't matter what other people say or think. This is what I live every day. This is my journey every day, and I need to do what I need to do to get through. And so it's been hard to make that adjustment and accept that. But unfortunately, some things will fall away if I've got to sleep, then some things will fall away.
There's a terrific book that came out about 3 years ago by a US author called Megan O'Rourke, who is living with a different autoimmune disease, but she made the point that when there's a disease that we don't know too much about, there's a tendency to psychologize, to look at it as something that is just in people's heads. What was your experience with that?
Yeah, very much so. There was a couple of ideas thrown around of, you're just going a bit loony, you're too tired. And then there was some anxiety, a lot of anxiety questions. Well, why are you so stressed? What are you doing that's stressful? And I thought to myself, I don't feel stressed. I'm enjoying what I'm doing. Everything was going well. But it was all just put down to anxiety. It was all just put down to stress. And I started getting incontinence. And that was the first time that I thought, there's something different here. There's something wrong here. But even after investigating that for 2 years with multiple gynecologists who said, no, we can't find anything wrong. You might just have to live with it. I was very surprised that doctors didn't put 2 and 2 together, didn't think about the anxiety, the incontinence, the stress, the fatigue as being one thing, instead of, well, you're just doing too much, you're just tired, you're just this. It's just something your body does. You just have to get used to it. So to see the holistic picture is really important.
Thanks for that. It seems to be a very common thread that the test results might be negative, but the body is telling you something very different. Our next speaker is Amanda Wells, a Brisbane resident who's a passionate advocate for raising awareness of AE. 7 years ago, Amanda, your daughter was 35, Hannah, and she experienced a very sudden psychotic episode. And it took 2 years for her to be diagnosed with AE and even longer to be put on a treatment that started to make a real difference. What did emergency doctors initially think was going on? You're on mute. Amanda?
I know, sorry. I did the same thing. At first, Hannah just went into an overnight psychosis. We were driving in a car, my husband and I, and bang, she rang the phone, and something was obviously very, very wrong. And she was happy-go-lucky. She was wonderful. Everyone loved her, outgoing. She was a practice manager for 10 years. And all of a sudden, she was totally, she had psychosis. She was paranoid, delusional, and she had auditory hallucinations. I finally got her to a local hospital. I couldn't drive her very far because she would go into rages. And she had dyskinesia as well. And
For people at home who might not be familiar with that, what was happening with that?
or in her mouth and in her face, she was having like tick-like movements, I guess you could say. And she couldn't, by then she couldn't turn a computer on. She couldn't cut and paste. She didn't know how to shower. She knew that clothes went on her, but she didn't know which way to put them on, so she wasn't changing. She couldn't even open a door. Everything, it was just so confusing. I took her into emergency, and she was totally paranoid. They said to me, well, you know, what's going on? Has she taken drugs or does she drink? I said, she does neither, ever. Has she had a trauma? No. And there's no family history of mental illness. Well, they said, well, all that means nothing. And they did a urine test for drugs, but then they had to put her into a psych hold, and they put her there for a couple of weeks. They didn't do any neurological tests, and she was getting worse. She was able to go home. Sorry, go on.
Were you able to see her consistently during that time when she was in a psychiatric unit?
No, it was a locked ward, and we were only able to see her now and then. I couldn't see a doctor. That was very frustrating. We had to call an ambulance one night when we did get her home, not long after, and they took her up to a teaching hospital. Busy. They took her away from me, and in that ambulance had a police escort because they said she was mental health. And this has traumatized Hannah now that she remembers the bits. You know, they put her on risperidone. She was refractory to that. Lucky she kept spitting it out. I am so glad. And this disease is so difficult to get diagnosed. We took her out, but the only thing that we could see was that must be mental health. Had no idea that it was more than that. Finally, we did get her diagnosed. It was through an endocrinologist, because Hannah's hair kept falling out. There were other things. Took her there, and she said, this is way above my pay grade. You need a neurologist. And they said, once we got there, it's like a chameleon. That it's like 1 minute you've got a psychosis, then the next minute everything changes, you know, symptoms change. She was having focal seizures. She was incontinent as well. She had shallow breathing. She couldn't walk more than 5 steps. She had anxiety, OCD. When it first started, she wasn't sleeping. She didn't sleep for 3 weeks, either did I. And so, you know, everything is just, it's chaos. And then she started to get fatigue, and she was sleeping like hours a day, hours and hours. And so many doctors said it was a complex case, too complex, because they were looking at all of the different symptoms, but not putting it all together. And finally, she got onto steroids, high dose steroids, and that actually helped her a lot. We could see a difference. But the problem was to put her on high dose steroids. They did that for 12, 18 months. And then she got osteoporosis. They finally said, let's put her into brain injury unit for rehab. They did, and which was fantastic. She had a lot of deficits. And so that's it briefly. And finally, we got to see an immunologist who looked at her and said, why hasn't she been on IVIG and rituximab? And within weeks, she was on that, and it was like Hannah came back. She started talking again. It was like she was back, and it was amazing. And now she's still on that.
It must have been hard to hear that after a few years of going through the health system.
It was actually hell, and it was horrible. And yeah, it traumatized Hannah greatly through that time. And I think that's one of the biggest things is the grief. But yeah, but once they get on treatment, and once a doctor will look at it from all the different symptoms, put it all together and say, yes, this is what it is. Let's have a look and see that some of those tests did come back with issues. Yeah.
Thanks, Amanda. We'll turn now to Michelle. Michelle's son was diagnosed 7 years ago at age 21. Compared to Amanda and Hannah, your journey to diagnosis was a lot more straightforward, but it seems it's still been difficult. What do you think made the difference at that point?
To be honest, I think at the point at which he was diagnosed, we were fortunate. And I so often hear and listen to the stories of others on this journey, and it is a journey. And I, as a parent, so often feel survivor's guilt, because I feel our son was just fortunate, because when he first presented, and he presented with a headache and vomiting, and whilst he was in A&E, he suddenly crashed and became psychotic and semi-conscious, and it was a very quick downward spiral. And he had a prodromal phase, which is a lead-up phase, which is not uncommon with his antibody, which is NMDA. But we didn't know that until hindsight, of course. But we were lucky, because the first hospital, and we went to 3 or 4 hospitals in our journey, he came under the care of an infectious diseases specialist, and she was tenacious and formed the view that he had viral encephalitis caused from the herpes simplex, and kept doing lumbar punctures, and there was never any proof of it. And she just said, we're determined to find the cause of it. And ultimately, through testing, rang us up when he came home after about a month, and he was on high-dose steroids, but high-dose antivirals, high-dose antibiotics. She indicated to us, look, I've got the answer, and it's a particular kind of autoimmune encephalitis, and you need to come back in straight away. Chances are he's going to decline very quickly, and you need to start immunotherapy. And so we did that, and he started immunotherapy that night, and the decline was almost immediate. And we had very similar experience to Amanda, where we had a lot of the dyskinesias. He had the autonomic dysregulation, so his heartbeat would, a couple of times it did stop. And I mean, on one occasion I was in one, I just shook him, and he just started to breathe again. And to the opposite, which was he would just go from sleeping to suddenly awake, to jumping out of bed, to running on the spot, because his heart rate was going at such a high level. And our son was an absconder. He would just run. And part of that was he was running to find himself. And because he had lost who he was, lost all sense of who he was. But when we got to ultimately our final hospital, which was probably only about within a week of the phone call from the infectious diseases specialist, we had the benefit of a neurological registrar who'd finished his training. He was just finishing time. And whilst this was not his area of interest, he was very much interested in a closely aligned area. So he was able to, once he had the diagnosis, had a lot more up-to-date information, and really with us also talking to him about it and being armed with a lot of information from the IAES group, he said, look, we'll treat it really hard and really fast. And so our son really was treated in that way. And I think, look, I never know if that was what led to the outcome that he had. We will never know. And that is why I feel always when I hear these stories how fortunate our situation is. That's why I still have the survivor's guilt.
Nonetheless, you told me last week you gained access to your son's medical notes years after he was diagnosed, and you were described as a difficult parent. Any regrets?
No, none. And the reason we got the notes was because he recovered. It took him 18 months to 2 years to recover. He came home with lots of cognitive deficits and executive functioning issues, and it was a slow journey to recovery. But I FOI'd the hospital because I always felt, being young, he'd want to travel eventually. And I thought, well, if I FOI, get the notes, scan them, put them on a USB, if he travelled and he relapsed, because ultimately they didn't find the cause for the production of his antibodies, that somebody might find the USB and plug it in, and there was his medical history. And in amongst that, I found the note that, yes, we were called difficult parents. And I'm so proud of that, because we had to advocate, and it's part of this illness. I think every person who is a carer or a patient, it's advocacy, which a lot of well-known illnesses, if you think about a breast cancer, for example, it isn't required. And it's just another added layer to this illness.
Just briefly, I don't know if we can be necessarily brief about this, but you're passionate about bias, who is listened to and who is believed. Can you tell us about your experience of that in the health system?
So our son, of course, diagnosed at 21, was a young, fit, really healthy 21-year-old. But our journey meant he was in hospital for a couple of months. And really, when he was really at an acute phase, by that point, he'd lost 15, 16 kilos in just a matter of weeks. His hair had grown out. He had this long, really scruffy beard and looked really gaunt. And on one of those occasions when he escaped the hospital, my husband and I went and found him, and he was on really running along Victoria Parade, which is one of the main thoroughfares here in Melbourne. We managed to get him back. We herded him back into the hospital. But in the meantime, the hospital staff had rung the police, and the police van arrived with 4 really burly police officers. And by then, my husband and I got him back into the bed, but he was being held down. He's being held down by my husband at one point, me, both of us at another. And the senior sergeant who was there, I spoke to him about it. I explained what it was, and I explained the illness. I thought I did it carefully and considerately, and he said, so it's drugs then. That was his first thing. And I just thought, I've just explained it. But at that point, a neurologist or psychiatrist was walking past to go into our son, overheard it, stopped, explained it. And then his whole attitude towards us changed. The whole attitude towards our son changed. It was caring, it was empathetic. He approached me and he said, look, we might have to handcuff your son to get him to the next hospital, handcuff him to the trolley. And it was just quite extraordinary. So I think for us who had a 21-year-old son, we were dealing with those inherent systemic biases of the perception of these officers of seeing this young, sick man, gaunt, scruffy, therefore it meant drugs, and it was anything but.
Yeah. Thank you, Michelle.
Mm.
Before we open up to all our panel members in a Q&A, I'm going to loop back to Mastura. Mastura, we've heard some pretty agonising patient journeys and all different. And even when you find the right professional, things can be difficult. Tell us about the research you're working on and what you think needs to be done for this condition to get the recognition that would really help people.
Yeah, thanks, Liz. As you can appreciate from all the stories, that this condition is very pervasive, and it, not only the trauma of the actual condition itself and the symptoms, but also, as you can see, the impact from the hospitalization, from the police force, from everything else that comes with it, the impact that it has on family members, on the caregivers, you know, the impact on the individual's employment, their studies, everything is basically affected by it. And so it is very pervasive, and it manifests in so many different ways, and the symptoms are quite varied. So in terms of our research, the idea is basically the ultimate goal is to improve patient outcomes. And we're trying to do that like the best way possible. But of course, we can't do that by just focusing on one area, because, you know, for example, cognition is affected in autoimmune encephalitis, memory, judgment, planning, attention. So that's affected in autoimmune encephalitis. But at the same time, individuals can have psychiatric manifestations, as we heard today. But there's a lot that needs to be also be done in terms of at the cell level or at the molecular level, so we can understand the different subtypes of the condition. So our research, so it's the Australian Autoimmune Encephalitis Consortium, which basically started from that one patient, or that one patient was the inspiration of the study. But now it has 14 sites around Australia, and we've recently gone to New Zealand, and soon we will have a site in overseas as well. So and we have 90 individuals, so 90 clinicians and researchers as part of the consortium. So it's a collaborative effort. Lots of individuals are contributing. And the idea is to basically understand the disease, understand the subsets of autoimmune encephalitis, to characterize the cognitive profile, and try and see what happens, you know, beyond the acute period, to try and understand many of these individuals have seizures. How are those seizures different in autoimmune encephalitis and the different subtypes of autoimmune encephalitis? But what happens? How many individuals end up getting drug-resistant epilepsy? What happens, you know, like, do we have any signatures in the brainwave pattern that can tell us about the different subsets of AE? And aside from that, also trying to characterize the molecular or the biomarkers, so the soluble proteins or other cell changes in the CSF and the cerebrospinal fluid, as well as in the blood, so we can distinguish the different subsets. But ultimately also, because one of the other factors is that prognosis, so what happens beyond the acute period, is quite unknown. We do know that starting treatment is it's very important. Starting treatment early is very important. But at the same time, many of our patients come in and, you know, they're a bit uncertain as to what's going to happen beyond that period. And as clinicians, we're also uncertain as to what's going to happen beyond that period. So we're trying to understand prognostic markers. So what can we do acutely that will help that individual at 12 months or at 14 months or 2 years or beyond that period? So that's what we're trying to do. So basically, I guess in a nutshell, the idea of the Australian Autoimmune Encephalitis Consortium is to really understand the disease, to try and see, you know, how we can identify it and diagnose it early, but what can we do to improve, so what can we do from a management treatment perspective to improve outcomes? But another, I guess, main reason for doing all of this research is because we have to make sure that, you know, we don't want to just do research for the sake of doing research. Otherwise, there's no point in that research. So it's absolutely meaningless otherwise. But we have to actually do it by having the individuals who who have actually been through this, you know, they've experienced it firsthand. They know exactly what it feels like to go to an emergency department and, you know, you're basically locked up in the psych, you know, part of that emergency department, or to know that, you know, your son is basically running down the road, and that would be, you know, like, how traumatic would that be for a parent, you know, to go through that. So we do know the impact of it, but we want to actually raise awareness, so resources and supports are available out there. So, you know, as Michelle said, you know, for example, for breast cancer, there's a lot available, and which is great. But we also want to make sure that for autoimmune encephalitis that it's recognized in the NDIS, because at the moment to get NDIS support, even though it can cause brain damage, even though it can have pervasive effects for day-to-day functioning in terms of memory and in terms of requiring assistance from someone else to even attend, the services or even go to appointments in the hospital, even though it has such impacts, it's extremely difficult to get NDIS. So we're trying to basically raise awareness so that it's recognized as an entity, as a disease, that NDIS can also basically be provided for individuals going through autoimmune encephalitis. But ultimately, because it requires all of us to come together, so it not just the ED physician, not just the neurologist, it requires all of us to come together, and we need to make sure that there's integrated guidelines. So if a GP sees a patient in a country town, they can go to the integrated guidelines and go, okay, these are the tests that I need to do. This is what should happen. Or if they see someone in the chronic phase of the illness, they can look through the integrated guideline and go, okay, now you need these supports and this is how we could access them. So I think our ultimate aim is to develop integrated guidelines to help with diagnosis and management of autoimmune encephalitis. Sorry for being quite long.
You've got your work cut out for you. Do we know at this stage if people need lifelong treatment?
So it varies from individual to individual. So we have had individuals that have needed long-term treatment, but it also some subtypes of autoimmune encephalitis are they present in an acute phase, and if it's treated, generally individuals do well. But there are some subsets you can actually get flare-ups of the illness, and then what also happens is that individuals can also develop seizures, and then the seizures can flare up, and that could be a long-term consequence of the disease. So yes, long-term treatment is unfortunately quite common, but we're trying to make sure that treatments are occurring acutely, so we hopefully don't have to rely on long-term treatment in the future.
And you mentioned the range of professionals who need to be involved. How important is allied health to long-term outcomes, what we know so far?
Yeah, so without allied health, I don't think we can actually, to be honest, we won't achieve the outcomes that we would hope to achieve, because it's not just like a neurologist making a diagnosis. But we absolutely really need neuropsychologists, because not only to assess the cognitive profile, to understand the degree of the impairment, but to really delve into the impact on the individual's day-to-day functioning, and to come up with ways of trying to slowly integrate back into day-to-day life and back to employment, and regaining their confidence to return back to society. So I think it's absolutely crucial in terms of neuropsychologists, social workers, physiotherapists, but also psychiatrists. Very important, because a lot of, as we heard, many individuals have anxiety as part of the illness, because it can affect the limbic structures, which are the regions of the brain important for emotion and memory. But aside from that, just the adjustment of having a condition such as autoimmune encephalitis can induce secondary anxiety. So I think it's very important we have access to psychologists as well, and so we can. It's definitely an illness that needs multidisciplinary input, and it can be managed by the individual themselves or by one clinician.
Thanks, Mastura. Loretta, Tiff, do we have time for one more question for the panel, or do we go straight into a Q&A? Yeah. Okay. So something that came up with all our panelists was how much grief is a feature of living with this condition. So I'd like to throw this open. Grief and loss. Maybe we start with Amber.
Yeah, grief and loss was a big one for me. As I say, I don't recall the year following my diagnosis. I was in hospital for 2 weeks, at home recovering for a year. I don't recall any of that. So there was a massive loss in my life of who am I? What am I doing in the here and now? And I can tell instances of when I was with people and they would say to me, "We've just done this." And I'd say, "No, we haven't." I said, "Yes, we have." "No, we haven't." And I had complete short-term memory loss. It was just completely gone. It wasn't even a recollection that there was perhaps something in the background. It was as if I'd said to you all, you know, at the beginning, I gave you the name of my dog, you know, what is it? There's just absolutely nothing there. And that I still deal with today, is that sense of, yeah, I've lost, I lose memory bits. I lose bits of the day, of the week, and some just don't come back. They fall away completely. I've stopped playing memory games. I've got labels on all my cupboards. I don't force myself into bringing back that grief, because to me it becomes a reminder of what I can't do. And I'd rather focus on the idea of, well, with this help, I will be able to do this or that. And as you've mentioned, that's why getting the NDIS for me was everything, because I could go back to doing my music and my karate. Before that, I was sitting at home. I'd do 2 hours of housework and I'd sleep most of the rest of the day. It was absolutely exhausting. So,
And Amazon, sorry, yeah, Amazon, Spotify. So at some point we will send you a link so you can. Yeah, she was she and remains a gifted songwriter and singer. Michelle, grief, loss. I guess the thing that you and Amanda have in common is it's not just grief about your kids not being who they were, at least for a time, but also your own identities and capacity to do other things besides managing this quite big disease.
It's interesting because for once our son started to recover, and it was obvious he was starting to recover, and it was a long journey, I really stopped working and I just stayed at home with him. He went into reactive depression, and one day sat me down and very quietly said, "Mum, I don't want you to get angry. I don't want you to react, but I'm going to tell you something." And he said to me, "Look, if I don't get any better, Mum, I am going to kill myself, because I cannot live my life like this." And so that was really not long after he came home. And then that was the start of the 18-month or so journey. And he started to recover, and being young and he was recovering, he started to get on with his life. And we've always said to him, "Look, if we're here, if you want to talk about it, we're not going to raise it with you. It might be traumatic for you to talk about it, but we'll talk about it when you're ready for it." And then probably about 2 or 3 years ago, we were in a car. He said, "I read a book," and it was by a doctor who'd become a patient after a diagnosis of a cancer. And he said, "Mum, I could really identify with things in this book." And I asked him what specifically. And he said, "Well, the doctor kept saying, asking people, 'Will I get better?' And I said, 'Yeah.' And he said, 'I kept asking you and Dad, 'Will I get better?' And you never said I would.'" And I was upfront and honest with him and said, "Well, that was because we simply didn't know." And it was one of those things. And so he's opened up a little bit, bits and pieces pop up. He is now a medical student. And I said to him, "How will you react when you see somebody with autoimmune encephalitis?" And he said, "Mum, I think I'll feel really sad because I know their journey." And I thought, well, that's just wonderful empathy. And I have to say, from my own journey, I think probably 2 or 3 years after he started to recover, I started to have panic attacks, and I didn't recognize them as panic attacks at the time. And I still, even now, if he has a headache, I'm taken right back there. And so I think I went through my own phase of, I don't know if you'd call it PTSD as much, but I would have to say to everybody here, you're in the caring role, but it does affect you. You may not think it does. You think, you're keeping it together and you're holding it together because you have to, because you're a parent or a carer or a loved one, but it will impact you physically, psychologically, and it will show itself in little ways. So just keep an eye on that.
Thanks. We've got about 10 minutes for a Q&A. Thanks, Loretta. Yeah. So any questions to kick off with? Feel free to unmute, Loretta. She just said no. Okay. Question 1. Okay. For Mastura, what proportion of AE patients have an antibody identified?
So that research varies from place to place and from time as well, because in the recent times of autoimmune encephalitis and the understanding or the identification of antibodies, it's relatively new and it's evolving. So the last count would have been 55% of AE cases would be seronegative, as in we do not have a known antibody. But that's, again, it depends on the region and depends on resources available and what tests are available.
Another question, why do some people have ongoing maintenance of treatment? For example, IVIG, rituximab, sorry, I've got that wrong, and some people don't.
So IVIG or rituximab, again, it depends on the subtype of autoimmune encephalitis, depends on the individual. So some individuals, like if you just have the acute treatment or with a following, a few months of treatment, that might be sufficient. Whereas with other individuals, they might have ongoing evidence of inflammation, and then it still is time for ongoing recovery. So in that scenario, we continue with immunotherapy, but it's very much individualized, and even within the subsets, it's very much individualized. And its response to therapy is also important to take into account.
Is AE more common in individuals from families where there are a number of other autoimmune disorders?
So anecdotally, we would say yes to an extent, but it hasn't really been like the data, because AE itself is quite rare. The data is not, it's not really there or validated, but there is some research to suggest that the certain, so HLA, human leukocyte antigen, so we all have that, but there are certain variants in that would predispose individuals to a particular type of autoimmune encephalitis. But generally, we don't consider autoimmune encephalitis as an inherited illness or one that's familial per se. Generally, it's an isolated cases in families. It's not considered to be inherited.
Yeah. Thanks for that. I'm going to throw one more question to all of you, which is, if you had, and I know this is probably a bit harsh, but I'm going to ask you to identify one thing that you think would be a game changer. Mastura, let's start with you.
Maybe I can go last because mine is not that important.
Okay. Yep.
Maybe Amanda can go.
Amanda, yeah, great.
One thing. I think it's that every carer and every advocate realize they have a voice and that there is hope, and to use that voice to speak up. And if there is, if you're not being heard, if you're not being respected, well, then you have the right to walk out and find someone who respects you or will listen to you. And I think that is my biggest thing. There is hope and you have a voice. And if we all could just speak together, if we could all raise that voice, all of us who have been touched with this disease, either as a patient or a carer, I believe this disease would suddenly get on the radar, and GPs particularly would have that as a red flag when someone comes in that looks a little bit off.
We've had a couple of comments and questions in the chat. It's really heartening to have some clinicians in the audience. Yeah, so thank you for those. I think Loretta's answered them in the text. Ebony, okay. I'll just read out her question. I'm a neuropsychology registrar. I know this service is not always available at every hospital, but I was wondering if you saw a neuropsychologist. If you did, was there anything that was most helpful to you or any strategies that you used the most? Anyone can answer this.
For us, that was actually the very pivotal thing that caused Hannah to be diagnosed, was a neuropsychologist who up here is very well known. And she just looked at all the deficits and said, this has to be autoimmune encephalitis, and got her into rehab. And now Hannah also sees a neuropsychiatrist. So yes.
Thumbs up for that one. Michelle, any one thing that might be a game changer?
I just have to echo Amanda's comments. Yes, there is hope. And also, I think as a carer and as a patient, you just want to be heard, and you want that treating team to listen to you, not just to pay lip service, but to actually listen and be heard. And I completely echo Amanda's comments.
Emma?
Yeah, absolutely. Exactly the same. Something that I have longed for now for the past 12 years has been just trying to understand what's happened, what caused it, what exactly was there for me, so that I could understand. You know, it's like waking up one morning and your arm just doesn't work. It just, and you can't fathom, you can't figure out why. So something that's been game changer for me has been my occupational therapist, who's got me through all of these tough seasons, and especially encouraged me to, what's the new version of me? What does it look like now? You know, I've lost 10 years, and so I still feel like a 22-year-old. So, okay, well then how do we move from here forward? What is it that we can do? And that's what led to me labeling cupboards. That's what led me to writing down a daily diary of everything that I did. Any meeting that I went to, was writing things down, because I sort of was challenged with a question very early on. I could either sit around and do nothing and definitely 100% get nowhere, or I could at least maybe try one thing and maybe get somewhere. And for me, that was big, because I thought, well, that's hope to move forward then. Because at that stage, I was so distraught. And through the neuropsychiatrist, they put me onto these anti-anxiety medications, which I'd never, ever needed. I never, ever thought I would need. I was a very, very happy young person, and we trialed coming off them, and that was almost a bit of a disaster. So to have that support of the neuropsychiatrist, who is not only a psychologist in terms of helping you understand and being the ear to listen to, but knowing why you're going through what you're going, understanding, yes, well, you are having anxiety because this part of the brain has been affected. That's why. It's not just you know, being angry for the sake of it, or you can't be bothered, or you're being lazy. There's actually a reason for it. And that was a big game changer for me, for sure.
Sounds like you need enormous reserves of resilience to just deal with the onslaught of AE.
Yeah, well, like I say, for me, it was, there were definitely times, again, where I didn't want to do it. And there were definitely times when I wanted to give up everything that I was doing. But I was grateful to have a very supportive family, and particularly my mum, who's been by my side with every step, to just keep encouraging me to keep going. You can still reach your dreams. You don't have to be the you that you were beforehand to achieve the things that you want to achieve. You can still do it from where you are. You can still do it with the things you have. And I struggled with that for a long time, because I desperately wanted the old me back, but it's not going to come back. And I have just decided that a different life path from what I thought I was going on from 10 years ago is now different. And I'm just determined to help other people. If I can help one person, it'll be worth it, because the unknowing is so hard. The unknowing. The minute I met one other person who had encephalitis, and we had a chat about the memory issues, it was like I'd found a soulmate almost. It was like, wow, he understands, he gets it, and he doesn't judge me. There's no judgment involved. There's a lot of judgment around, when, as I say, I looked perfectly normal. A lot of people didn't believe me. And so to have that support and to keep pushing through with the things that I wanted to do, for me, that was the only option. Otherwise, yeah, I'd be hiding in the corner under a couch somewhere, just sleeping my days out.
Thanks, Amber. Thanks, everybody. This has been a really moving and comprehensive and a terrific conversation. If you'd like to stay involved and informed about the work of the consortium or be somehow involved, there are a few ways. If you have an AE diagnosis, you can join the Autoimmune Encephalitis group on Facebook, enroll in the study, so details through the consortium website. And as with all studies, you'll need to meet certain criteria. You can also follow us on social media on X or Twitter at STM Neurosci. That's STM as in School of Translational Medicine, Neurosci, or on LinkedIn at Monash Translational Medicine. And we are really keen to have more people with lived experience, either as someone living with AE or a carer, on our advisory panel. So again, see our webpage. Thanks, everybody. Thanks to our community engagement program CARE for supporting this event. And thank you to all our panellists tonight. Many, many thanks. And members of the audience for your insightful questions and your time. Good night.
Good night.
Thank you very much.
Thanks for having us.
Thank you.